I'm Roger Blanks. I'm an epidemiologist from the University of Oxford, and I'm first author on the paper looking at evaluation of colonoscopy performance based on post-procedure bleeding complications and the development of a procedure complexity adjusted model. My co-authors are Nickerson and Julietta Patnick from the National Screening Programme, Colin Rees from South Tyneside and Matt Rutter from North Tees, who are both endoscopists. Now, bleeding works well as a performance measure because although it's relatively rare, it's an important complication which occurs often enough for us to use it as a routine performance measure. By that, I mean a colonoscopist may experience this problem a number of times per year. Perforations are less useful as a routine measure in this way because they occur at less than one procedure per 1,000. However, similar methods could be used for perforations as well. So in this study, we used regression models to examine the risk of bleeding during colonoscopy against a number of factors, and the most important of these turned out to be largest resected polyp size, gender, any polyp located in the cecum, and patient procedure fitness measured using the American Society of Anesthesiologists ASA grade. So the PACER method, which stands for Procedure Adjusted Standardized Adverse Event Ratio, calculates an expected number of events based on the total amount of total national data or any other standard, and allows each colonoscopist to have an observed and expected number of events calculated based on the patient distribution characteristics of gender and ASA grade and procedure complexity measures of largest resected polyp size and location. In particular, if polyps, and particularly large polyps, are located in the cecum, this is associated with a considerably increased risk. So in this way we can allow for procedure complexity by looking at the observed number of bleeding events against a calculated expected number, and this is a really good method when adding data over a number of years because we just add up the numbers for each year, so the number of adverse events from bleeding, the number of expected events from bleeding. It's statistically stable, it's a nice simple way of expressing the performance data. So if we expected, based on national data, 15 events and we observe 45, which is a PACER of 3, so that's 3 times as many events as would be expected, we'd have reason for wanting to look closer at these figures. Now on top of that we can use standard statistical methods such as funnel plots to look for outlying performers, either looking for PACERs which are very high, which could be suggestive of poorer performance, or also very low, where we may want to look further to see if this is genuinely good performance, alternatively some problem with the recording of the data. And in any national programme, of course, we're always concerned that data is being recorded in a uniform way. Overall, we hope this methodology will improve the performance of the national programme by early identification and support of poor performers and by passing on good practice where performance is found to be particularly good. Thank you.